Yeah. Hello, good evening, good afternoon, everyone, and welcome once again to our monthly webinars on critical care medicine. This is number 18, and we have an interesting topic this time, hypoalbuminemia in the ICU. Um, Interesting because we see it quite often. Sometimes we may not be too sure what to do about it. A lot of physiology involved in this concept. And for that reason, we have an excellent speaker who is well suited for such a topic. He's been here with us before. He loves physiology, and we look forward to hearing from him and his experience. Dr. Sharad Patel, thank you once again for accepting our invitation and joining us once again in the webinars. How are you doing?
Good. How are you doing, Septain?
Great, man. Nice to see you again. And
Good to see you too.
whenever you're ready, take it away.
Okay, perfect. Thank you again for having me. I appreciate the invite as always. So today we'll be talking about hypoalbumin in the critically ill. So this is a complex topic. Let me see if I can move on to the next slide. There we go. So this is the complex topic. So because when I think about hypoalbuminemia, it's almost that we use this and I'm sure this might be in many countries, but this concept of the chicken or the egg, right? The is the chicken, does the chicken come before the egg, or does the egg come before the chicken? This circular reasoning type of thing. Where you use another analogy of like the canary in the coal mine. When the canary goes in the coal mine and there's a like toxic gases in there, the canary will die. But it's the coal mine the issue as well. So it's kind of this like circular reasoning that when you see low albumin, does it lead to worse outcomes? Or is it the things that lead to worse outcomes leading to the hypoalbuminemia? So this is a really complex question. I think we're really just starting to understand a little bit more as we understand some of the more kind of the pleiotropic, the additional effects of albumin beyond just oncotic pressures. So when you look at hypoalbuminemia in the critically ill, greater than 70% of elderly hospitalized patients are hypoalbuminemic. Greater than 60% of the critically ill, they develop hypoalbuminemia. So if they came in with an albumin of 3.2 and they develop sepsis, septic shock, they have chronic wounds, nutrition is not great, they over time may develop hypoalbuminemia as well. So the prevalence range is wide. So, as we know in the ICU, uh, ICU patients are as varied as they can be, right? So you can have surgical ICUs, medical ICUs, neuro ICUs, each with different physiologies, different pathologies. But this incidence is relatively high amongst all these patients. The clinical challenge is really looking at it, is this a marker of severity or is it therapeutic target? And when I look at an albumin of 1.8, is an additional factor from my discussions of goals of care, or is it something that I need to be treating, that I need to be giving additional albumin to, right? So these are some of the things that we'll think about. I honestly feel like this presentation will lead to more questions than answers, but I think that's where we are with the albumin as a therapeutic medication, is that we probably still have more questions than answers. So albumin beyond the textbook. So it's a multifunctional protein. So the common concept. So I remember going through medical school. I'm thinking about albumin as like a purely oncotic protein, right? It's the most predominant protein in the body, and it's 80% of colloid osmotic pressure. So it does have like a big effect on this. It's a transport carrier. So, for example, Lasix. Lasix is predominantly albumin bound. So in patients with nephrotic syndrome, diuresis is a little bit more difficult because less Lasix is actually being delivered to the proximal tubule. pH buffering. So as we adjust the anion gap equations, when we adjust the anion gap, we adjust it for albumin, right? Because albumin is involved in a significant amount of the pH buffering and then drug binding, as I mentioned. Emerging roles are some of that albumin may have like scavenging reactive oxygen species effects. So some of the benefit that, let's say you have a patient with sepsis, septic shock, and you give them albumin, it may be acting as a free radical scavenger because it binds nitric oxide pretty significantly. And as we know in sepsis, nitric oxide is significantly high. And that's why we have this kind of vasodilatory shock. So it could act as a nitric oxide reservoir for BP regulation. So theoretically, as you give the albumin, it can bind some of this nitric oxide. reduce that vasodilatory effect and maybe improve hemodynamics through that method, even beyond the osmotic effects of it, pulling fluid into the intravascular space, which, by the way, this concept of pulling fluid into the intravascular space, this actually has been modified. There's a modified Starling equation now that's happened in the past 5 years, which I really recommend looking at. But there's newer thinking that albumin giving it, so the whole concept of giving albumin, pulling fluid back into intravascular space, the interstitial space. This may not be as true as we used to think. Again, every simplistic process that we thought for most things in medicine, including albumin, our understanding is getting a little bit more complex. And then potentially this may lead to more therapeutic effects down the line too. A little bit about the structure and kinetics of it. It's a large molecule. The usual half-life is about 21 days, and it synthesizes about the liver, which is the only synthesizer of albumin, synthesizes about 10 to 15 grams a day. And there's some thinking that the synthesis actually increases. Why do we get low levels? Which we'll talk about a little bit. Um, and then it also has anticoagulant properties as well. So if we potentially go back and look at this retrospectively, I have a feeling that the bleeding prevention or the bleeding will look a little different in hypoalbuminic patients versus like patients with normal albumin. So the pathophysiology revolution, so our understanding is a little different. So we should think traditionally, it's a simple mathematical equation, right? In critical illness, there's decreased synthesis and there's increased losses, and that leads to hypoalbuminemia. Modern understanding is a little bit more complex. So when you have hypoalbuminemia, you may have impaired hepatic synthesis, but this may not be completely due to nutritional deficiency. So let's talk a little bit about that. There's increased tissue utilization as well in critical illness, redistributional changes. So when you're critically ill, you're chronically inflamed, there's damage to the capillary layers that keep albumin in the intravascular space. And this may be contributing as well. And there's also enhanced transcapillary escape, which I'll talk about a little bit. There's a paradigm shift from this, from simple deficit model to a complex dynamic equilibrium. So the inflammation connection. So hypoalbuminemia, as I think about it, when I see someone who's critically ill, I don't just, sorry, one second. I don't just think about it as someone who has a nutritional deficit. I think about someone who likely has higher tumor necrosis alpha, higher IL-6, and they have higher cytokine release. This increases capillary permeability, and you lose albumin from the intravascular space, and it goes into the interstitial space. There's also endothelial barrier dysfunction as well, and I'll talk a little bit about that. When you're critically ill, you have more VEGF, so sepsis is a perfect example. And this destroys the endothelial barrier. It causes endothelial barrier dysfunction. The nitric oxide also increases vascular permeability. So in sepsis, this is increased. And the glycocalyx, which is, you can think about the glycocalyx like it's a waxy layer at the capillary layers that separate intravascular versus interstitial. So when you have someone with sepsis, the glycocalyx is damaged as well. Other things that damage the glycocalyx, things like hypernatremia, things like overvolume administration, crystalloid, this can lead to degradation in sepsis as well. So what's interesting that in critical illness, synthesis may actually increase, but transcapillary leak increases as well. So this leads to shortened half-life. The final result is that there's distribution of volume expansion. So if you give fluid in this situation, or you give albumin in this situation, you will have leak and you have enhanced transcapillary escape, leading to net hypoalbuminemia. So the capillary leak paradigm. So let's talk a little bit more about the endothelial glycocalyx. So you can think about the glycocalyx as kind of like the materials in your knees. It kind of buffers the joints. And when you don't have this, so, excuse me, one second, just sneeze. And so when you don't have this, you get a loss of barrier function, you get increased capillary leak and more albumin transcapillary escape. The inflammatory matter, the mediators, so when in sepsis, you get more complement activation, you get more prostaglandin effects, you get cytokine-mediated damage, and oxidative stress impact. All these things increase capillary leak. And this is why when you see some of these sepsis patients, especially after the administration of the crystalloid, more and more interstitial edema develops. So you had this situation where you had intravascular depletion, but increased overall total body fluid. The classic examples of this is when you have like a systemic disease, like systemic capillary leak syndrome. Sepsis kind of matches this, which is just a kind of a capillary leak syndrome in itself. So what's the threshold at which you would consider someone to be hypoalbuminemic? We think about this, and again, it's grams per liter or milligrams per deciliter. So the overall convention is just using 30 grams per liter. So anything below 30 grams per liter, this is considered to be hypoalbuminemic. And where does this number come from? So a lot of the major trials use this as kind of the main kind of cutoff. And the RCS analysis evidence, there's a rapidly increasing mortality in patients with less than 30 grams per liter threshold. So this is kind of the critical inflection point. So if you were to look at a mortality curve, you might see a rising mortality as it approaches 30, but there's an exponential increase at the 30 level. The MIMIC-4 database, which looked at 18,000 patients, found that 30 grams per liter is also the best cutoff. So these trials of the EARS sepsis trial and the ARIS maintenance study, which I'll talk a little bit about, both of these use 30 grams per liter as the threshold. The RLC analysis noted that there's an RLC around 0.78 to 0.8 as a prediction of mortality when hypoalbuminemia is less than 30 grams per liter. So how do you quantify risk? So when I see a hypoalbuminemic patient, I already see, all right, this person, compared to the patient who has normal albumin, at any given level of sepsis, any level of critical illness, the mortality will increase. And so when there was a meta-analysis done on this, 90 studies were analyzed, and they noted that every 10 gram per liter decrease, you get a dramatic increase in mortality odds. So, and in the same way, any 10 gram increase, your hazard ratio for death shows an improved mortality compared to someone who has a normal albumin. So per 1 gram deciliter increase, you get a reduced 73% risk of mortality. So it has a really good prognostic power. And in my own analysis and my own research, I found that albumin is consistently one of the best predictors of death, even better than lactate at times. What about organ system consequences? So organ system consequences can be including the kidney, the lungs. So let's talk about the kidney for a second. So just having hypoalbuminemia, it's an independent risk factor for AKI development. So the odds ratio is around 1.81. Just chronically, there's higher CKD progression as well. So odds ratio of 2.49 when you have hypoalbuminemia. When you have someone in the ICU, patients on CRRT, so this patient's already likely highly inflamed, highly sick, critically ill. Severe hypoalbuminemia less than 2.5 grams per deciliter or 25 grams per liter. It has a greater than 57% higher mortality than someone who's on CRRT. So highly prognostic and highly likely consequential and causal as well. What about the respiratory concerns? So they found is that when you look at the analysis, patients with hypoalbuminemia will have longer mechanical ventilation durations. When you look at the ventilator-free days as well, there's a positive correlation with it. So the higher your albumin levels, the greater your ventilator-free days as well. There's a complex relationship here. So the classic thinking is that maybe a lower albumin leads to more capillary leak. And this may be one mechanism, but it's not the whole story. There's the surfactant function. So albumin affects surfactant as well. So as we know, when surfactant is reduced, you're going to have worsened alveolar capillary barrier function. So your predisposition to capillary leak will be higher. And so at any given point, your predisposition to ARDS will be higher. So ARDS severity is high with hypoalbuminemia. And in the same way, ARDS may also contribute to hypoalbuminemia as well. So infection. So is infection the cause or the consequence? So I think there's a bidirectional relationship. So there's in infection and sepsis, surgical site infections, hypoalbuminemia increases risk for worsened outcomes. Patients with hypoalbuminemia have increased risk for C. diff as well. But does the C. diff infection also lead to hypoalbuminemia? Yes, that's correct. So mechanistic plausibilities could be altered antimicrobial pharmacokinetics, and we know this too because it, there's some evidence to suggest that we should probably be doing more drug monitoring for patients with hypoalbuminemia because it's harder to predict drug levels in these situations. The theoretical effect of hypoalbuminemia may be that the volume of distribution of the antibiotic might increase, so the actual therapeutic effect might actually be reduced. There's impaired immune function and compromised wound healing in patients with hypoalbuminemia as well. So this question still deserves some more analysis. Does the infection lead to hypoalbuminemia? Does the hypoalbuminemia predispose to infection? It's probably both. So patients with hypoalbuminemia may have more infection going forward. I wanted to pause there for a second because I've just given a lot of information. Any questions, thoughts so far? All right, keep moving. So can we just replace albumin? Right, so this is a good question. In patients who are critically ill, sepsis, septic shock, can you give albumin and does the outcome improve with this or not? So the SAFE trial, which was a sepsis trial done a while back, they looked at about 7,000 patients and they found that albumin was safe compared to saline, right? This is around the time where I can't remember if the other colloids, the study trials that showed that there was the starches, they showed increased mortality compared to crystalloids. And so this was interesting because they were like, all right, was albumin S is safe because the other colloids don't seem as safe. And they noted that there was safety, and in the sepsis subgroup, there was a trend towards mortality, although this was not statistically significant. The additional thing they found was that TBI, the traumatic brain injury patients, these patients did worse with albumin administration. So it's probably important to identify the patients that will actually benefit and provide albumin for them as a targeted therapy. So where albumin may matter the most. So there's a couple of trials. So one's done, one is not yet. So there's the EARS trial, the EARS study. They looked at 20% albumin versus saline in septic shock. So the results are, there's still prelim analysis out, but the prelim analysis for the EARS results showing there's no mortality benefit, but there is faster shock resolution and less fluid required. The ARIS trial is still actually happening. So there's a maintenance out. This is more of a chronic study. So what they're noting is that if 28-day duration persistent albumin administered, if you can keep the albumin level in 30 grams per liter, does the outcome improve or not in sepsis? So this is going to be something that the results will still be coming out for. So what about long-term albumin therapy? So I mentioned the ARIS studies looking at that. So consistent, persistent albumin administration. So let's look at a few different situations. So we do know that in large volume paracentesis, 8 grams, administering 8 grams of albumin per liter ascites drained. There's a well-established protocol for this, and there is benefit for this. In the ANSWER trial, so ascites, this evidence is pretty much kind of set in stone. So this is a general practice. So when you do a large volume paracentesis, you give albumin back, and this makes sense. In the ANSWER trial, long-term albumin in uncomplicated ascites demonstrated benefit in preventing more ascites. So there may be something to this of actually administering chronic albumin, although this may not be a practical thing to do. So there's a paradigm shift in albumin use where in the old way, it was kind of volume replacement. And now you might consider it to be kind of a medical therapy. But you have to keep cost into account as well. What about the pharmacokinetic effects of it? So I think a pharmacist's job is probably a little bit more difficult in patients with hypoalbuminemia. So antibiotics, including beta-lactams, vancomycins, fluoroquinolones, sedatives, and analgesics like propofol, midazolam, fentanyl, and anticoagulants as well. All of these are highly protein bound. So standard dosing may not be adequate. So one recommendation would be that in severely hypoalbumic patients, we might consider checking drug levels more often for optimal drug administration. So why food alone won't fix it? So there used to be thinking is that, okay, hypoalbumic patients, traditionally, you would think that these patients are nutritionally deplete, right? So that nutrition may improve that. So this is not true. There, when you look at patients with severe anorexia nervosa, a lot of them have normal albumin levels because their liver is still functioning well. And it's not high inflammation. Excuse me one second. Sorry, my allergies are acting up a little bit today. And so the reality is that the inflammation is probably what's suppressing the synthesis. So cytokines may actually block hepatic albumin synthesis. And even though you take in normal protein, you can give tube feeds, give proper nutrition, you still may maintain hypoalbuminemia. So it's just not just a nutritional issue, it might additionally be an inflammatory process as well. Monitoring and trending. So should we be trending albumin levels? So I think most facilities they're following and they're trending albumin. Um, uh, but what is the therapeutic benefit of this? So I see sometimes where the patient has an albumin of 2.1 and they're in shock. Albumin is more likely to be administered, right? And there might be something to this, but again, I think that the jury is still out on this. We know it's safe, and there might be some benefit in sepsis septic shock patients. But trending it, there's probably the single measurement is probably of limited utility. Trending values, if it's trending downwards, it probably gives us a little bit more of a trajectory information of is this patient clinically improving or not. So it's almost like I would imagine it's the biomarker for total health. And so just like we trend creatinine for kidney function, we might be able to trend albumin to see if it's going in the wrong direction. Is this a situation where our current therapeutics are not working? In the same way, the rising albumin is likely that the patient's clinical state is improving. So you can trend it for trajectory. Falling was likely with concerning trajectory. Um, comparing albumin in the setting of, like looking at albumin in the setting of inflammation is important as well. So if you have someone with a low albumin, high CRP, that's probably the most dangerous, worst trajectory talking because the chronic inflammation still exists or the acute inflammation still exists. So you should look at the albumin in context of your CRP, procalcitonin, and lactate as well. Okay, so the bedside decision making. So how do we actually look at the decision making for this? So for the bedside decision making, I think in general, if you have someone in septic shock and the albumin is less than 25 grams per liter, this might be someone that you might want to consider replacement for. The trending considerations, albumin, the half-life is changing, right? So when someone who's critically ill, sepsis, septic shock, normally the half-life is around 21 days. But in someone with sepsis, septic shock, the half-life of this can be about 1 to 2 days because of the processes that we already talked about. So a hyperencodic albumin patient renal impairment, this person is going to be at risk of volume overload. So if you have AKI, you have your and you're administering lots of albumin, you still can develop volume overload with this. So it's just because the volume is a little less. The most albumin solutions have a lot of salt as well, and this may be contributing to volume overload as well. So you really have to look at kind of the individual patient, but I think it's reasonable to assume that patients with less than 25 grams per liter and they have septic shock, along with your usual crystalloid, giving albumin might be a prudent, rational thing to do just based on some of the evidence we have so far. So the cost of albumin, so you have to take this into account as well. So in the Western world, we don't think about cost enough, right? So any treatment that you're giving, you want to do a cost benefit analysis of it. Crystalloids is like pennies to the dollar compared to albumin. So when you're giving albumin, you're giving something that's dramatically more expensive than the alternative treatment. And you have to think about is the net benefit worth the additional costs? And this is kind of the jury's still out on this, right? So the SAFE trial, when you look at the economics of it, there's no clear benefit in the general population. So you probably shouldn't just make this a default. Targeted therapy, again, like we talked about in septic shock with less than 25 grams per liter, this might be a consideration. And also cirrhosis with ascites, this might be a consideration as well. There's also the opportunity cost, right? Is that instead of giving additional albumin for someone who's hypotensive, should you just start vasopressors early, right? And also additionally, just infection, sepsis in general, you want to make sure that you're prioritizing source control before all else. So future directions, right? So this is a topic, like again, when I looked at all the literature and I was working on this presentation, the literature on this is increasing, but again, there isn't a large amount of information on this topic. Again, then we keep going back to kind of that chicken and the egg picture as well. So it's I think we're going to learn a lot about albumin going forward as we consider a lot of the other mechanisms beyond just kind of oncotic pressure, including the inflammation, free radical scavengers, nitric oxide binding, and things like that. So ongoing research, we'll see what the ARIS trial results, the results are pending, and we'll see what happens. In the future, we might be even looking at personalized albumin therapy based on things like albumin, hypoalbuminemia plus high CRP versus hypoalbuminemia with low CRP. Is there a benefit with one patient versus the other? And then I think really when you think about it, just this, when you have a patient that comes in with hypoalbuminemia, it's probably one of the best biomarkers of just overall health, right? It kind of covers hepatic synthesis, it covers nutritional status, and covers free radical binding. It looks at oncotic pressure. So it's a really, really good biomarker for looking at and talking about how a patient might be doing. So hypoalbuminemia is likely a very powerful prognostic marker. And again, we've seen this over and over again. Treatment should be target underlying inflammation. So when you're giving it, think about it as more than just oncotic replacement. You're saying that you theoretically looking at is maybe you're reducing inflammation as well. Consider replacement improvement scenarios, and then monitor trends over days and weeks and absolute values. Specific situation that we discussed that I really want everyone to take away from this presentation is that in overall just the ICU management strategy, fluid management with coordinated protocols, don't just think about that this is less volume. It's a little bit more complex than that. Source control, again, main kind of goal for if any patient with sepsis, but this is a good additional kind of treatment consideration. And then antimicrobial therapy. So again, the pharmacists are going to need to be more involved in patients who are severely hypoalbumic for drug level monitoring. And that is it. Sorry, so this was a little bit more of a shorter presentation, but again, the literature is still kind of lacking on this topic. So I'll kind of open it up for questions and discussion.
Great. Thank you, Dr. Sharad. That was excellent. Like you said, more questions than straightforward answers, but yeah, definitely a start of good discussion and something for us to think about. So I'll open the floor now for any questions. Feel free to write them in the chat, or you can unmute yourself and ask your question, or even comment, share your experience if you have experienced the albumin dilemma in your ICUs. As the audience is thinking, maybe if I could start with one or two questions. So, as you said, that the albumin is tricky. So sometimes it may be physiological, it may be pathological. So if you are treating, let's say, for example, the way this slide shows that if albumin is below 25 and you have septic shock, you consider replacement. So up to what target would you consider replacing this albumin? Would you be going for a certain number or some clinical picture?
Yeah, that's still like I think that's still a question today. I think if just being rational and noting that the 30 grams per deciliter, that's when the mortality dramatically, when it gets below, increases. I think a reasonable target could be 30 grams per liter. But even beyond that, I would be looking at clinical efficacy. If I give albumin and I'm not seeing a therapeutic benefit in terms of like physiologic parameters, I'm not sure I would be doing the same thing continued. But that newer trial I was talking about, looking at chronic administration in sepsis patients, I think that's going to give us a little bit more information to see if there's a target that we should be following and if we're going to have clinical improvements or not. But the reasonable number would probably be 30 grams per liter.
And how often would you check? Like, would you make it a routine to check all patients for albumin or?
I think it would be daily. I don't, so I don't think so. Lactate changes dramatic, like can change rapidly. Albumin's not going to change as rapidly, right? So again, like the processes are so much more complex. Hepatic synthesis is a lot more slower. And so all of this kind of like affects, I don't think we should be checking it for more than like once a day. I don't think you would check it multiple times a day like a lactate.
Even after you've replaced it, you'd still just maybe just do it daily, probably. No?
Exactly. And I'd just be following the clinical picture and seeing if like that shock patient, are they getting better or not with just the albumin replacement?
Right. Thanks. Let's see if there's any other question. All right. Don't see any other question. Okay, so maybe let me just make a small announcement as if there's some other question that comes up after that. So you might have all seen the adverts going around, the announcements going around, which are related to the upcoming AFRICRIT conference or educational conference, I should say, that's happening. Let me just put up the slide if I can, so we could all follow. I hope everyone can see that one. Right, so we have AFRICRIT, and this is something that we've been doing every year. We had a very good conference. Dr. Sharad was part of that. I'm sure some of you were also part of that conference last year. We have another one happening this year again in October. So that's around 6 weeks from now, 5 to 6 weeks from now. And based on the feedback that we received last year, we decided to have AFRICRIT this time more of a course-based conference. So we have 3 different courses that we are going to be doing this year, each lasting 2 days, so a total of 6 days. And we have a course on mechanical ventilation, one on what we call neurocritical care, and one on what we have been doing every year, which is the fundamental critical care, or FCCS. So the mechanical ventilation course is something that has been developed by the Cleveland Clinic and the experts from the Cleveland Clinic. Very well received, very well recognized course in the US and now also being taught worldwide in other centers. So it's going to be coming to Tanzania to us for the first time. And I've done a part of this, and it is an excellent course, very structured. So we'll be doing just the fundamental levels. So it's going to be basic. Even somebody who does not have much experience with ventilators would benefit from this course. And it's a start to gain your mastery in this level. So that's one course that will be on the 6th and 7th of October. And then following that, we have a neurocritical course. So this has 2 parts. This will be the first part is what we call the ENLS, Emergency Neurologic Life Support. So this is a course that is developed by the Neurocritical Society in the US. And it is a series of lectures where the goal is to acquaint the learner on how to manage different neurological emergencies in the ICU or in the emergency. So there are protocols that they have prepared, evidence-based protocols, algorithms that we will be discussing. So it's an excellent starting point for anybody who does deal with neurocritical patients. And then the part 2, which is something different, is we have the speakers that the trainers have developed custom workshops around ultrasounds in neurocritical care. So the focus will be on things like transcranial Doppler, and how it would be useful in patients with stroke, in patients with TBI, in patients with ICP, raised ICP, and etc. So excellent opportunity, very interactive, and also possibly of hands-on practice will also be there. And then the third course is what we've been doing every year, and this is really like the foundation of critical care, FCCS. developed by the Society of Critical Care Medicine in the US. We have done it for 3 years. Today, this time will be the 4th year. And so take advantage of this. It has a lot of different topics that we'll be going through, lectures and skill stations and interactive sessions. And this will be the last of the 3 courses on 10th and 11th. So I will be sharing this all with you on your emails. And if you have any more questions about this, feel free to write back to me and I will try and help you out there. Yeah, so anybody who has any more questions based on today's talk? If not, then we would end here. Sharad, thank you so much once again for taking time out on the weekend, speaking to us, giving us this experience. It's really good presentation, gives us a nice flow on how to think about albumin going forward, and definitely an area to look out for and to keep updated also.
My pleasure. Thank you so much.
Yeah, thank you all. Take care.